Thanks, Mark. I mean, that last story, always look around the room and see who's laughing with you, because the people from DH were not laughing when I was doing that from that point of view, and that may have contributed to my demise. So I'm going to talk about the Think Kidneys programme, and I know you've had a talk about a local QI project looking at acute kidney injury, and apologies that I missed that session, and what I say may overlap a little bit. But a bit of orientation and a bit of talk about how the NCPOD report was actually critical for us setting the scene for this might be useful. I mean, I think of acute kidney injury as an intermediate health state. People generally have acute kidney injury as a complication of other illness, but the problem about it is I consider it to be a force multiplier. So whatever you've got, if you've got acute kidney injury on top of it, your outcomes are poorer, be that survival, length of stay, morbidity, etc. from that point of view. So very little actually comes into the direct nephrology domain, and it's just as well given you've got close to 2% of UK nephrology sat in this room today, not doing any work. But I think it is an important marker of illness severity, and certainly when I was a trainee, kidneys were very poorly understood. It was, sort of somewhere off in the horizon there, and people didn't really understand it. But yet, there's clearly a potential to improve care, and we need to reduce avoidable harm, which is a mantra that you see through all reports such as this. And in addition to that, we need to improve resource utilisation in any healthcare economic system providing for healthcare. So adding insult to injury was the report. You've already seen the front cover from Mark on that. And it was proposed by the Renal Association, and it was a simple premise that it was a serious problem. So in terms of numbers, we would estimate that there are about 500,000 cases of acute kidney injury every year across English hospitals in the inpatient setting. That's without anything that's going on in the community that we're not aware of from that point of view. That any specialty may be faced with people with acute kidney injury as a complication or de novo of their inpatient stay. And there's a degree of uncertainty or therapeutic nihilism about what you can do about it in terms of improving things from that point of view. And I'm not going to say too much more about the report, other than the fact it followed a standard format which was examining processes of care around people who died in hospital with AKI, and looked at things that were going astray with those individuals to try and illuminate where we might actually put our effort in the future. And again, no surprises here, but right across the pathway, systemic failures in AKI, a lot around education, but failure to recognise and manage AKI, failure to recognise and manage the complications you get from that condition, and problems about the structure in terms of referral and support when people got to more advanced stage. And behind that, linking into other reports and other NICE guidance, were failures to recognise the acutely ill individual as a precursor to that. So a lot of powerful messages in there, and between 2009 and 2012-13, several centres around the UK started embarking on exploratory work about what could be done around this issue, sort of asking the question, what could be done. And NICE also started producing some guidance. I'm not going to talk about the NICE guidance because that came out in 2013, about the time that we commenced the Think Kidneys AKI programme. And it was basically headed up by NHS England, a commissioning organisation working with stakeholders. So there's the first big collaboration, is can you actually get those people in the room to talk about something you need to develop from that side of things. And in addition to that, one of the dangers was, could we avoid it looking like a sort of nephrological tea party? That we needed to make sure that we had a broad church of experience at the table from that point of view. So in our steering board, we had patients, we had commissioners across the commissioning pathway, so both local and at senior level. We had nephrologists, we had intensivists, we had pharmacists, ultimately we had people from care home setting and so on. So we tried to build a group of people who would actually shine a lens on the problem from different angles from that point of view. And if I said that was all in my head when we started, that would be a grotesque lie. Because at the start it was all very simple for me. I took the work we'd done locally and thought we were just going to sort of replicate that and scale it up. But like all these things, one of the big successes was actually to allow it to grow organically by giving people permission to explore and deal with the issues and the trust that they need. And that's very important, because quality improvement is often about uncertainty and how you manage that. So we set up a number of work streams to fund that, and our reporting mechanism was into NHS England patient safety. And that was actually very important in the early days for us, because it goes to the question of permission as to how you effect change. So sometimes people are slowed down by, do I have permission to do things? So one of the things that we did a lot of work on was branding. Think Kidneys as a brand. I never sort of believed in branding, but it sort of gives you, it's both a question and it's also a request for people to think about kidneys. And it became quite a useful shortcut for the community to really sort of come together, and it gave us visibility in terms of expanding our messages. And we had a website and all that stuff, and we had media people in, and it was all very useful from that point of view. We had to be very clear about our initial objectives. So for us, what we wanted to do is we really wanted to do three principal things that would be markers of success for us 3 years after we commenced that project. So number one, we wanted to establish a flow of data and information that allowed us to furnish one of the building blocks for audit and quality improvement to come. And that was very key for us to do that, and it became quite complicated, but you'll see how far we've got with that. The second thing is that we wanted to provide clinicians and patients with education and information about acute kidney injury, which informed local care, individual care, but also informed a degree of organisational care from that. So that's quite a broad ask, and that was why it's very important that we brought in people from many sectors. So Renal had experience in terms of dealing with chronic kidney disease in the previous 10 years, and that's a very successful thing that we probably don't talk about sufficiently, but one of the criticisms is we didn't really bind primary care, for example, into our message. But we were very keen to have primary care right from the off, and so primary care were a big part at the table. And the third thing, which I think is really important to make things stick, so this goes to the sustainability thing, is to give the commissioning organisation, the commissioners and organisational leads, the understanding why AKI was important to them, wherever it sat in the process. Because otherwise it was just another medical thing from that point of view. So I'm really going to talk about, in brief, some of the things that we delivered out of that. As a point of necessity, they have to be sort of vignettes of what we do. But the first thing that we did, which really broke open our ability to affect acute kidney injury, actually came through the NHS England patient safety team. So you may recall, maybe you don't, maybe you blanked it out as being a terrible dream, but in 2013 the commissioning structure changed, and the patient safety section of NHS England came into being. Mike Durkin was heading that up at that time. We created this mechanism for patient safety alerts, which went out to organisations. On my board for acute kidney injury and Think Kidneys, we had one of the leads for the patient safety section, and she said in about the third meeting, well, let's produce a patient safety alert to break this open. And so what we did is that we formulated a working party with laboratory personnel and nephrologists and IT companies to look at how the laboratory handles simple data. And from that, I'm not going to run through the algorithm on the left, you'll be pleased to hear, the definition of acute kidney injury risk, the AKI warning test score, is defined by looking back over previous serum creatinine. So no new blood tests are done, you're just actually using a computer algorithm at the point of care to deliver a warning score that may be acute kidney injury from that point of view. And so that got professional sign-off, but the trick was then to embed it into a level 3 patient safety alert with a 1-year implementation time. And that came quite early in the process from that point of view. And in an instant, that brought the topic to the fore from that side of things. There were other things that we did from the commissioning lever side of things. So on the right-hand side of the panel, the top was our second patient safety alert, which came later on, which was, as you know, the patient safety alerts have different levels. So 2 is about highlighting tools and facilities to try and improve care. And so we by then built up a library of stuff that people could refer to. And then in the bottom right-hand corner, you've got some very preliminary early data, which is now actually a year old, sorry, no, actually wrong slide, sorry about that, my cold, I'm going to blame my cold now. But we also brought in a national sequence. So one of the issues was knitting together the pathway, and we were concerned that trusts would do all of this, but that the GPs would be blind to it. So we brought in a national sequence that brought about coding for AKI, which was then communicated to general practitioners, and thereby linked up the recovery phase. And those were all done through the system rather on the clinical level. So this is all happening in parallel with other things going on, but one of the things that we also wanted to do was break apart how we actually approach the individual patients. So I don't know how many of you are familiar with electronic alerting in AKI, but it can be a term that's used without precision from that point of view. I think we need to be really, really careful about it. So people often talk about the NHS algorithm as being an electronic alert. It isn't. What it produces is a test result that says this person may have AKI. The alerting is the bit that leads to you knowing that that person may have a risk of acute kidney injury and then responding to it. And so we were very careful that we wanted to knit that pathway together. So we had this idea that the algorithm was about improving detection, that we then needed a process whereby people were alerted, and then we needed better response to people coming out of the NC pod report. So the detection I've talked about, for the alert, that was actually about using electronic systems in the main to ensure that people acknowledged and knew that someone may have AKI. So most of the organisations came up with systems within their IT to allow this to happen. And then in terms of response, Mark has already talked about care bundles. In the 2 or 3 years before Think Kidneys started, people were starting to explore care bundles as a way of improving the care from this point of view. And one of my colleagues produced an electronic format, and what happened was that the AKI warning test score would come through in our lab, the doctor would be alerted, and they would be mandated to fill out the care bundle or say why they weren't filling out the care bundle. And we were able to produce a paper that showed that if you didn't fill out the care bundle or you filled it out late, outcomes were poorer than if you responded in a timely way. Now the content of that care bundle wasn't anything clever. It was about fluids, recognition of sepsis, thinking about whether there's obstruction, thinking about the drugs, managing the underlying illness of the patient. And we'll come back to that as a theme in terms of when we explore whether there's benefit. So those first 2 slides were probably where I thought Think Kidneys was going to get to, but what we moved into with that wider group of people was thinking about some bigger messages. So over the years we've thought about where are the areas where people are more at risk of acute kidney injury, where is vulnerability in the system. And one of the most exciting meetings I ever went to was a group of care homes in Birmingham who came together. So this is healthcare assistants, nurses, no doctors other than the doctors who came from Think Kidneys, coming to understand the importance of kidneys and coming to understand how they could improve on the health of their patients by managing hydration, as it became, and dealing with drugs and so on, and understanding that side of things. And out of that we produced some things. So they're not novel. So on the left-hand top corner you will see that we've got the sort of the are you dehydrated type chart. That's coming for criticism in some quarters as not being particularly sort of robust in certain settings. Indeed it isn't. But this was more about kidney health now. So we were turning our talk into our message into kidney health. How are we going to ensure people protected their kidneys? We talked about fluid balance, and we started developing acute kidney injury risk scoring mechanism. We produced a paper. There was also the business about drugs and basically some of the committee, including myself, felt that we needed to ban the word nephrotoxic as being a word that was full of connotation, and we were, as nephrologists, particularly careless in terms of using it. So the idea is, the standard thing is a patient comes in with AKI, they've got heart failure, and the first thing they get told them is those ACE inhibitors and that spironolactone, they're nephrotoxic, don't have those, stop those. And what we've got to understand is that the patient then gets the message, those drugs are dangerous and toxic to my kidneys. They're not nephrotoxic, they're situational in terms of other illness that's come along from that point of view. So we've tried to work hard in terms of precision about how we communicate and precision in terms of how we talk to the patients themselves to understand. And that comes through really in our educating and guiding documents that we've got on the website. So top right-hand corner, the British Kidney Patient Association have got a leaflet around acute kidney injury. Top left-hand side, we've got core elements of the care bundle that came out of further work. And bottom left-hand corner was fantastic work that was undertaken by GP colleagues looking at how we respond within general practice. And indeed, the Royal College of General Practitioners have launched an AKI toolkit and QI learning package off the back of this work, which is an absolutely phenomenal piece of work. I'd recommend you going and looking at it. The bottom right-hand corner then is just to remind me that suddenly, though, nephrology were linking up the issues. So we became aware, really, that there was a huge linkage between acute kidney injury and chronic kidney disease, and that's taken from an article in the New England Journal of Medicine, which is basically saying that the two feed off each other. So if you've got chronic kidney disease, you're more likely to have AKI. If you have AKI on top of CKD, you can progress more quickly. If you've got AKI, you can get de novo CKD, and suddenly the agendas start to merge. And so it was a useful construct for us to really think carefully about how we got over a kidney-friendly message. So Mark talked about the bit about collaborating and sharing. So Think Kidneys as a portal has brought together a lot of these case studies and so on. So if you go onto the website, we still populate that with stuff that people are doing, and that can be big or small. So we've got the care homes video up on there, we've got stuff around AKI specialist nurses going around hospitals. We've got individual case studies, so oncology, for example, a big vulnerable population, and we've got stuff about mental illness and the higher rates of acute kidney injury within that population. So allowing people to build up a resonance with the area that they're dealing with has been very fulfilling. And then the other thing that we worked hard on is public awareness around kidney health. So again, at the start, and this was pushed on me actually, I wasn't really keen to spend the money on MORI, but they were actually quite useful. And we were doing this because acute kidney injury is a terrible term, let's be honest. I trained in the East End of London. Acute kidney injury meant a baseball bat around your back if you'd upset the local hoodlums, as we used to say in A&E. And we wanted to understand what was the public's awareness of that term acute kidney injury. But what we turned up was actually that only half of the population know their kidneys make urine. Now that's a real wake-up call, and that's not unique to the UK. So the US have done the same thing now, so have some countries in Europe. So if we're going to start getting people to understand the value of kidneys in disease, we've actually got to explain to them why they're important when you're well. And so that's brought off a whole set of new campaigns. And you know, clearly the alcohol guys are doing well because alcohol is the #1 harmer for kidneys according to that population from that point of view. And I remember going on the radio and again the radio announcer asking me, livers, kidneys, are they the same? I said, well, they're all awful, but anyway. Okay. So the final slide from what we did was this system measurement thing. So in the green box in the middle, you've got the lab producing this AKI warning score, and then the red shows you the patient management system taking it, alerting the individual in whatever way you get organised, and then you get a response. But the next thing we wanted to do, and that was in the patient safety alert, was to generate a message to the UK Renal Registry. So the UK Renal Registry is now culling data from every lab at source with the right permissions to create a master patient index of episodes of acute kidney injury. We now cover 90 to 95% of laboratories send through data on a monthly basis. Now, why is that important? Well, if we just count what's going on, that's still quite powerful in terms of looking at variation across the piece. But the idea is then creating linkage with HAIRS and other areas so that we can actually create an AKI registry without anyone having to input additional data. So we're using data that's already in the system. We can link that potentially to GP systems as well. So we can look at drugs. We can interrogate NICOL in terms of trying to work out whether there's any linkage in their databases. So there's huge power, and it also gave us a vehicle to support quality improvement programs at a regional or a local level, which is yet to be fully realised, but is now beginning to come online. And that's just some of the data that we've got. We've now got about 500,000 individual cases of AKI in the database, so it's the largest database of its kind. So all of this is leading to system improvement. That's where we're at, and I think that Think Kidneys has allowed us to bring what's quite a significant issue. It has 500,000 episodes a year. 100,000 of those people die, not necessarily because of, but they certainly die with AKI, and it costs anything from $500 million to $2 billion, depending on how you make the sums. But what we're trying to do is then feed it into a number of projects with Q, with Health Foundation, and a number of others. So patient safety collaboratives in their first iteration had an AKI stream. And there's unpublished work as yet from London. Chris Lang led a improvement collaborative looking at the impact of a simple system to improve outcomes from that point of view. And I'll just use that at the very end. Tackling AKI, use exactly the same system. You've got a driver diagram, you've got a sort of a process map from that point of view. That's still yet to be published, but what I can tell you is that it certainly shows improvements in length of stay and people moving to higher stages of AKI. But we have two relatively recent papers published which look across the Northwest, showing improvements in hospital-acquired AKI and in terms of time to recovery, which are important. And here's the most recent, which is taken from the Manchester AHSN group, which showed significant improvement in hospital-acquired AKI by a multifaceted improvement bundle. So what's the potential benefit of this approach with OFF spelled with 0 rather than so I told you 100,000 people die. NCPOD said there were probably 30,000 in whom care could be improved. That was the figure. Conservatively, from these papers and other papers, we think that probably translates, if we could do that universally, to 10 to 20,000 lives saved a year. That is bigger than anything else. That dwarfs what sepsis can do from that point of view, to put that in perspective. Of course, there is overlap with sepsis, so they're not, we've got to bear in mind these things sit. The second thing is it reduces morbidity. So length of stay, hospitalisation, but also longer term outcomes are potentially improved from that point of view. And it reduces the impact upon the patients from that point of view. And then the system benefits are huge. If we consider that every one of those 500,000 episodes we save one bed day, that is 500,000 beds that we save annually, bed days we save annually across the NHS in England. That is a colossal number, and if you round, start now doing your back of the envelope calculations, you've got a sum of about 100 million. And if it's 2 days, which some of the studies have shown, you can double that. So I think there is still huge potential that we need to deliver. Returning to Chris Lang's work, he showed a 43% reduction in mortality. That was admittedly in an acute admission population, so it's not universal across the system. But that was a well-constructed study, and I'm looking forward to the formal publication of that. And that was double what they achieved in the sepsis group. So there's additionality of benefit in managing this. So to summarise, I'm sorry, I think I've gone over by a minute or so I apologise for that. But this wouldn't have happened without NCPOD, I think that's fair to say, because NCPOD was the thing I could take to my bosses at NHS England and say, I think this is an important thing to do. And it gave us also the framework of how we were going to approach the problem. I think the data flows have been established. We're yet to leverage that in a quality improvement way, but expect a big report in April. I certainly think we provided resources to individuals, and there's more to be done, and people are working on that. And I certainly think it is something that commissioners come and talk to me about. So they still come and talk to me about, now we're in STP world, what can we do about acute kidney injury across the piece? Because it's seen as a big issue that needs to be solved. So although I was sacked as NCD, renal sort of carries on in a way, because it's an important intermediate healthcare state. And I guess my final challenge is to say, do we now, 10 years on, need to think about actually looking to see how far we've moved on? We can use the master patient index to get global data. We can create practice patterns because we now know what works. Can we interrogate that? And we can use the master patient index to target in-depth analysis of individual AKI cases. So I think the work is part way there. We've still got a lot more to do, but it's been exciting and it's been fun. So thank you very much indeed for listening.